Now, ultrasound scan of the brain and the spine. Now, it is difficult because the brain is a very complicated structure. You can, on the outside, you can see the cerebrum, cerebellum, and the spine. But on the inside, there are a lot of deeper structures with all
Recording
sorts of
in progress.
Therefore, if you want to scan the baby's brain, you have to know the anatomy very well. So let's start examining the brain anatomy. Now, the brain is made up of two cerebral hemispheres, and each cerebral hemisphere is made up of four lobes: the frontal lobe in front, the parietal lobe on top, the occipital lobe at the back, and the temporal lobe on the side. And the two cerebellar hemisphere is connected in the middle by a large bundle of nerve fibers called the corpus callosum. And if you remove the cerebrum, you will be able to go in to see the deeper structures. Now, the green thing is the corpus callosum, and on each side of the corpus callosum, you can see the basal ganglia. And underneath the corpus callosum, you can see the two fornixial column, which is connected to each side of the, which is connected to the hippocampus on each side. And when you remove this basal ganglia, you will be able to reach the thalamus, hypothalamus, and the pituitary. And if you remove the thalamus, you will be able to see the brainstem, which is composed of the midbrain, the pons, and the medulla oblongata. And you can also see the medulla oblongata is connected to the spinal cord. And at the back of the pons, you will be able to see the cerebellum, which is composed of two cerebellar hemisphere, and there is a connecting nerve fiber, the thalamus, in between. So cerebellar hemisphere and the thalamus in between. So the innermost layer of the brain is made up of ventricular system, which is a system of spaces containing cerebrospinal fluid, CSF. Which is responsible for the production and the circulation of CSF, both within the ventricular system and also the subarachnoid space of the brain. So when you look at the ventricular system, it's like a bird. So you can see that the bird has a head, it has two coxcomb, and there's a neck, the body, the wings, the tail, and also the leg. So the biggest part of the ventricular system is the lateral ventricle, which is inside the cerebrum, which corresponds to this coxcomb here, which is made up of the frontal horn, the body, the occipital horn, and the temporal horn. And the head of the bird is actually the third ventricle, which is situated between the two thalamus. And the body of the bird is actually the fourth ventricle, which is inside the cerebellum. So the body, you can see that is connected to the leg, which is the central canal of the spinal cord. Now, you can see that all these ventricles are interconnected with each other. This lateral ventricle is connected to the third ventricle by way of the interventricular foramen, which is this small thing here. And the third ventricle is connected to the fourth ventricle by way of the cerebral aqueduct of Sylvius, which is the neck of the bird here. The fourth ventricle is connected to the space outside the brain. It is connected to the cisterna magna, which is the space surrounding the cerebellum by way of the median aperture, which is the tail of the bird here. It is also connected to the subarachnoid space surrounding the cerebrum by way of two lateral apertures, which are the wings of the bird, and it is also called the lateral apertures of the Luschka. And the leg of the bird, as I have already mentioned, it is the central canal inside the spinal cord. So this is the brain anatomy, and you can see that it is very complex. So how do we examine the brain? We examine the brain by taking planes. So it refers to the three orthogonal planes, which is the axial plane, which is essentially transverse plane, the sagittal plane, which is a vertical plane cut in the midline, and the coronal plane, which is also a vertical plane but cut anterior-posteriorly. So these are the pictures. These are MRI pictures, but then ultrasound pictures are more or less the same. And how do we examine fetal brain by ultrasound scan? We follow guidelines, and the most important guideline is here written in the ultrasound of ONG in 2007, and this is the old guideline. And we know that in just last year, a new guideline has been published, but it is only the part one. We're still waiting for the part two. When I studied the old guideline and the new guideline, actually there is not much difference. So I'll spell out the difference to you later. So, we are still sticking to the old guideline. So in the old guideline in 2007, the examination of the fetal brain is divided into two parts, the basic examination and the fetal neurosonogram. Now for the basic examination, it is the examination that every fetus should have during the routine anomaly scan. And the fetal neurosonogram is actually reserved for those who are at high risk of having CNS abnormality or those who is suspected to have CNS abnormality. And what is the difference between the old guideline and the new guideline? And for the old guideline, I can say that it is only a change in the naming of the two parts. The basic examination is changed to screening examination. Fetal neurosonogram is changed to targeted fetal neurosonography, and that's it. So we can stick to the old guideline. Okay, so the screening examination that every fetus should have during routine morphology scan is composed of three axial planes. The three axial planes are the transthyromic plane, which is also what we call the BPD plane because we are taking BPD in this plane. And the second plane is a transventricular plane, and this plane is parallel to the first plane, but it is a little bit higher. The third one is a slanted plane, which cuts through the cerebellum, and therefore it is called a transcerebellar plane. So let us take a look at these three planes one by one. Now, this is the transthyromic plane, which cuts through the thylamus. In this plane, you will be able to see a white line here, which is the fourth cerebri or the midline. And this red box here is a very important structure, what we call cavum septum pellucidum or CSP. This is a fluid-filled rectangular box here. And this is a very important structure, and the absence of this structure denotes that there is very serious brain abnormality. And on the side of the CSP, you can see the two little comma-shaped thing here, which is actually the frontal horn of the lateral ventricle. And then when you look at the structure behind the CSP, it is the thylamus with the third ventricle in between. And the structure behind the thylamus would be the brain. And in this plane here, we measure the BPD, and we measure from the outer table of the bone to the inner table of the bone. And then we also measure the head circumference, which we put the caliper outside, on the outside of the bone. And in this plane, the most important structure, as I have already mentioned, is the CSP, because the absence of CSP denotes a lot of very serious brain abnormality. The second plane is a transventricular plane. Now, in this plane, again, you can see the white line in the middle, which is the fourth cerebri or the midline, and you can also see the very important structure CSP here, and the two comma-shaped frontal horn, and you can see the xylem. But in this plane here, this is the transventricular plane. You can see the whole lateral ventricle from the frontal horn to the body to the atrium. But then you can only see the ventricle on the far side, but the near side you can't see it very clearly because of the shadowing of this of the skull bone here. And inside the lateral ventricle, you can also see this white thing here, which is the choric plexus. And in this projection, we can also see the green line here, which is the parietal occipital fissure. This parietal occipital fissure is very important in that it is a landmark for which we know where to measure the ventricular width. Now, how do we measure ventricular width? We measure at the level of the POF, and we measure the atrium of the ventricle from inner to inner. I'll show you how to measure the ventricular width later. And therefore, in this projection, the most important thing is to examine the lateral ventricle and also to measure the ventricular width. The third plane is a slanted plane cutting through the cerebellum. In this plane, again, you will be able to see the white line, which is the falx cerebri and the midline, the red box, which is the CSP, the comet-shaped frontal horn, and also you can see the thalamus and the third ventricle, the midbrain. And the most important area is this area here, which we examine the cerebellum, which is composed of two cerebellar hemisphere and also the vermis in between. And then the space behind the cerebellum is what we call the cisterna magna. And in this projection, we would measure the transcerebellar diameter from outer to outer. And if the cisterna magna is abnormal, then we would also measure the size of the cisterna magna from inner to inner. So in this plane, of course, the most important structure is the cerebellum, cerebellar vermis, and the cisterna magna. And these three are being housed in a place called posterior fossa. So if anybody tells you that there is something wrong in the posterior fossa, it is referring to cerebellar hemisphere, vermis, or the cisterna magna. So if a fetus is at high risk of CNS abnormality, or if the fetus is suspected to have CNS abnormality, we would go for a targeted fetal neurosonography. And for targeted fetal neurosonography, it is composed of a series of sagittal planes and coronal planes. And I think the most important sagittal plane is this one, mid-sagittal plane. And the most important coronal plane is this one, which is the transthylomic coronal plane. So let's take a look at mid-sagittal plane. Now, in a mid-sagittal plane, you would be able to see the CSP, but then the shape is rather different. It is like this shape. And above the CSP, you can see the entire corpus callosum, the whole corpus callosum. You can actually examine the whole length of the corpus callosum. And below the CSP, you will be able to see the thalamus and the third ventricle in the middle, and also and we can also see the cerebellar vermis here, and with the fourth ventricle in front and the cisterna magna at the back. So the most important structure in this mid-sagittal plane is the corpus callosum and the cerebellar vermis, because you can examine the whole thing at this plane. And the transthylomic coronal plane is like this. And you can also see the CSP, which is a triangular structure here. And above the CSP, you can, and on this side of the CSP, you can see the frontal horn. And above the CSP, you can see this corpus callosum here, and you can also see the thalamus on each side of the CSP. And in the middle of the thalamus is the third ventricle. And in this plane, the most important structure is the corpus callosum and the CSP corpus callosum. So coming to the spinal cord, and you know that the spinal cord is a tubular structure which has a central canal inside. And this tubular structure ended in this area, what we call the conus medullaris here. And below the conus medullaris, you can see the nerve fibers called the equina, and the spinal cord is anchored to the coccyx by way of this fiber here, what we call filum terminale. And you can see that this spinal cord is housed inside a column of inside the spinal column, which is made up of a series of vertebrae stacked up one on each other. And therefore, we have to know the anatomy of the vertebra. Now, a vertebra is made up of several parts. The part in front is the vertebral body, and the part at the back, we call it posterior elements, and sometimes we call it neural arch. So it is composed of the spinous process, the lateral, the lamina, and the transverse process. And you can see that between the spinal between the vertebral body and the posterior neural arch, you can see a space inside. This space is the spinal canal, and the spinal cord is being housed in this spinal canal here. Now, how do we examine the spinal cord? Again, we take three sections, three orthogonal planes, the sagittal plane, the coronal plane, and also the transverse plane. Now, in the sagittal plane, we examine the whole spine, and we examine the posterior element and the body, we can see that the alignment is normal without any bridging. But then also very important structure that we have to examine is this overlying skin. We have to make sure that the overlying skin is also intact. And in the coronal plane, we examine the transverse process of the vertebra, which would be aligned just like a tram line here. It is parallel. And then you would also be able to notice how the tram line tapers in the sacral area. And in the transverse section, we would be able to examine the vertebral body one by one. So the vertebral body is made up of the vertebra one by one. The vertebra is made up of the vertebral body in front and the neural arch at the back. And you can see that the transverse, the lamina and the transverse process is in the form of a Chinese character 8. And in between is the spinal canal, and you can see the spinal cord here, and the white thing is this spinal cord. And you have to also examine the skin overlying the vertebra to make sure that it is intact. And a very important structure that you have to examine is this conus medullaris here. And you can see the central canal, and then you can see the spinal cord, and you can see that the spinal cord ends here, where this area is called the conus medullaris, and the level of the conus medullaris is usually situated at or above L4. Anything above L4 is normal, below L4 is abnormal. And you can also see this caudate quina here. And after knowing how the anatomy of the brain, how to scan the brain and the spinal cord, we can go to see some common congenital abnormalities of the brain and the spine. For the brain, for the common congenital abnormalities are neurotube defect, midline defect, and posterior fossa abnormalities. Now, neurotube defect is by far the most common, so it can be in the head or in the spine. If it is in the head, if the whole cranium is absent or the whole brain is absent, it is anencephaly. And if there is a small hole with herniation of the brain tissue, it is cephalocele. And in the spine, if there is a hole inside, it is spina bifida. And for midline defect, there are two categories. One is a disorder of cleavage. It means that the two sides of the brain does not separate. They just fuse together, forming an abnormality called holoprosencephaly. And in the midbrain, in the midline, the most important structure is the corpus callosum, and therefore the most important abnormality is the agenesis of corpus callosum. And posterior fossa, I have already told you that it houses the cerebellum, and the posterior fossa abnormality is mainly the abnormality of the cerebellum, and which I'll show you one by one later. But before I go to individual congenital abnormalities, let me show you one ultrasound sign, which is very important and which is very common, ventriculomegaly, which means that the cerebral ventricle is dilated. Now, but the first important thing that you will need to learn is how to measure the lateral ventricular width. Now, first of all, we have to use a standard plane. The standard plane to measure the lateral ventricular width is the transventricular plane, which is this plane here. And you will be able to see the CSP, and you will be able to see the lateral ventricle in its entirety. And then you can, the area that we measure the ventricle is the atrium, which is this area here. So the atrium is that big. So which level should we measure? I have already told you about this PLF here, parietal occipital fissure here. We measure at this level. We only measure the atrium, and we measure the atrium from inner to inner, and we are taking the measurement perpendicular to the atrium. It's not perpendicular to the ground, it's perpendicular to the atrium. So we place the caliper in the inner border of the atrium. So this is how we measure the lateral ventricular width. Sometimes we call it atrial width. So if the atrial width is more than 10 mm, we call this ventriculomegaly. But mind you that this is an ultrasound ultrasound sign only. It is not a diagnosis, and it may be a manifestation of underlying pathology. Now, according to the ventricular width, it is divided into mild ventriculomegaly and severe ventriculomegaly. For mild ventriculomegaly, the ventricular width is between 1 to 1.5 cm, and it's very, very common. It occurred in 1% of the fetuses. It means that for 100 fetuses, we would be able to see one mild ventriculomegaly. Now, mild ventriculomegaly can be totally normal. It can be just a normal variant. It can regress on its own, but it can also progress to more severe degree, and sometimes even for mild ventriculomegaly, it can be a manifestation of very severe underlying pathology, which I'll show you later. Now, for severe ventriculomegaly, the ventricular width is more than 15 mm. It is rarer. It occurs in 0.3 to 1.5 per thousand fetuses. It means that for 1,000 fetuses, we can only at most see one. And sometimes we also call it hydrocephalus. And for severe ventriculomegaly, it is usually pathological. It is usually not a normal variant. Now, just to show you an example of mild ventriculomegaly here. So this is the transventricular plane. You can see the CSP and you can see the whole lateral ventricle. And then you can see that the lateral ventricle is dilated. But then when you look at the area surrounding the lateral ventricle, you can see the white band, a white band. So this white band is actually ventriculitis of CMV. CMV is cytomegalovirus infection. So when you see a white band surrounding the lateral ventricle, the first thing you should be in mind is CMV infection, cytomegalovirus infection. Now this here, the panel on the right-hand side shows you a case of severe ventriculomegaly. Now this is a transthymic plane, thymus, and you can see that the third ventricle is dilated. So when you look at this one, the third ventricle is dilated, and then you look at the lateral ventricle is grossly dilated, and you can also see that the midline here is perforated. And it is a very severe case of hydrocephalus and causing the rupture of the midline. So let us come to the most common congenital abnormality, which is neural tube defect. Now, let's start with some embryology. Now, you understand that the fetus is actually the embryo that begins as a disc. And this disc would roll up on its own. And when it rolls up, it fused together at the middle and then progress caudally and cranial and fuse together to form a tube. This is what we call the neural tube. Now, when the neural tube fails to fuse completely, it would cause neural tube defect. So if in the head region, it fails to fuse totally, there would be no cranium and the brain would disintegrate and resulted in anencephaly, which is the most common neural tube defect we can see. But when there is only just a tiny hole in the head region with a herniation of the brain tissue or meninges, it is called cephalocele. If there is brain tissue inside, it is called encephalocele. When there is only meninges, we call it meningocele. And most of the time, the neural tube defect is in the spine. And when it is in the spine, we call it spina bifida. And now we give them a new name called spinal dysraphism. Now, the most common neural tube defect is anencephaly. The primary pathology is absent skull bone. The whole skull bone is absent. Now, therefore, in the first trimester, we would be able to detect anencephaly. But in the first trimester, the manifestation is not absent brain. It's just absent skull bone. When the skull bone is absent, the brain would float in the amniotic fluid. This is what we call exencephaly. And when the brain is exposed to spinal fluid, it would just disintegrate. And therefore, by second trimester, there will be no brain whatsoever, and therefore we call it anencephaly. Now, anencephaly is usually an isolated abnormality, but sometimes it can be associated with other abnormalities. And the most important abnormality is there's a neural tube defect elsewhere in the body. In this example here, you can see anencephaly together with the whole spine opened up at the back. Just to give you some examples of anencephaly. Now, because we are doing routine first trimester nuchal scanning for first trimester Down syndrome screening, and most of the anencephaly is being picked up in the first trimester. Actually, we don't see anencephaly anymore in the second trimester, and therefore I can only show you first trimester examples. Now, this is the normal for you to compare with. This is the first trimester fetus here. You can see that this fetus here, there is no cranial fault, and you can see how the brain is floating in the amniotic fluid. And when you take a coronal section, you will be able to see the baby's face, 2 eyes, 1 nose, 1 mouth, and above the baby's face, you can't see the skull, and instead you can see the 2 cerebral hemispheres floating in the amniotic fluid. And when you take a 3D photo, you will be able to see the baby's face, eyes, nose, mouth, and hands. You can see walnuts being placed on top of the baby's face. It is because there is no cranial fault and there's no skull, and then the brain is floating in the amniotic fluid. So when you look at this projection here, the coronal section, it's just like a Mickey Mouse, and therefore we call it a Mickey Mouse sign of exencephaly or acrania. So this is the hypothesis for you to compare with. And as I have already told you that I don't have a second trimester example. So this is the late first trimester example that I can show you of a case with anencephaly. Now, this is a normal for you to compare with. You can see that in this fetus, there is no skull bone and there is virtually no brain. There is a little bit, tiny bit of brain here, but virtually there is no brain. But when you take a coronal section, you can see the 2 eyes, the nose, the mouth, but above the eye level, you can't see the brain, any brain at all. And when you take a 3D, you can see the 2 eyes, and above the eyes, you can't see any brain at all. And therefore, when you look at the baby projection, coronal section of the projection here, it is just like a frog. And therefore, we given a name called frog-eye sign of anencephaly. So this is the hypothesis for you to compare with. And coming to a hole in the brain, a hole in the skull. So it is called cephalocele. So cephalocele is the primary pathology is that some part of the skull bone failed to close, and the brain or the meninges just herniate out. If the herniation is composed of brain tissue, it is called encephalocele. If the herniation composed of the meninges only, it is called meningocele. So these are the 4 basic types, depending on the location of the herniation. It is occipital, parietal, frontal, and basal. So the most common type is still the occipital type. Now, just to give you 2 real-life examples of cephalocele. One, first of all, this one is a case of meningocele. First of all, when you look at a cross-section of the brain, you can see that the skull shape is strange. It is just like a lemon. And then the second thing, you see that the ventricle is dilated. This is ventriculomegaly. And when you take a section lower down, you will be able to see at the level of the cerebellum. This is the cerebellum. You will be able to see a bone defect here, and the meninges just herniate out. And this is called a meningocele because we do not see brain tissue here. Now, this one, when you see the baby's head is like this is called lemon sign. And why is there lemon sign? It is because this meningocele, this herniation here, creates a suction force on the frontal area of the brain, particularly at the front, at the suture here. So the frontal bone just scallops and forms the shape of the lemon. And why is there ventriculomegaly? And it is because of the suction force. The cerebellum is also almost sucked out. It just crashes against the skull bone, and therefore it would cause obstruction to CSF flow, and therefore the ventricles will be dilated. But when you take a look at the second case here, when you look at the transcerebellar plane, you can see that the brain, the head shape is normal, the cerebellum is normal, everything is fine. But when you take a look at areas above the cerebellum at the transventricular plane, you can see the ventricle is not dilated at all. But at the back, you can see a big hole here, and the brain just herniates out. And you can see the cystic mass here, there are brain here. So this is a case of encephalocele. But in this case here, you can't see Lemon sign, you can't see ventriculomegaly. Why? It is because the defect is situated above the cerebellum at level, and therefore there would be no obstruction. There would be no obstruction to the CSF flow, and there would be no ventriculomegaly. So coming back to spina bifida. Now, spina bifida, the primary pathology is that some of the vertebra failed to close, and sometimes the skin also failed to close. Now, there are two types. One is open spina bifida, and the other is closed spina bifida. For open spina bifida, the defect is not covered by skin. For closed spina bifida, the defect is covered by skin. So for open spina bifida, there are two types. The first type is what we call myelomeningocele. It means that both the neural tissue, the spinal cord, and also the meninges just herniate out. So you can see that the spinal cord herniates out, the meninges herniates out, and there is no covering skin, and therefore you would be able to see a cystic mass at the back. The second type is what we call myelocele or myeloschisis. Now, in this type, there is a hole there, but only the spinal cord herniates out. The meninges does not herniate, and there is no covering membrane, and no covering skin, no covering membrane, and therefore you would not be able to see any cystic mass. Instead, you would just see a hole, and the hole containing neural tissue. And the second type is a closed spina bifida, in which the whole lesion is covered by skin, and the example is a meningocele. Only the meninges herniates, no brain tissue, and also this is covered by skin. So on the outside, you can't see any cystic mass here. You can see a mass covered by skin, but you can't see any cystic mass. And the most common site is lumbosacral area. So how do we scan spina bifida? The most important thing is not to look at the spine, it is to look at the brain. Because for open spina bifida, there are three important cranial signs for you to pick up. When you see these three important cranial signs, you will know that there is an open spina bifida at the bottom. So what are these three signs? The three signs are: one, banana sign. Now, banana sign denotes the shape of the cerebellum. The cerebellum is just like, instead of a dumbbell shape, it is just like a banana. So why is that so? It is because the spina bifida at the bottom, it pulls on the whole brain. So when it pulls on the whole brain, the cerebellum and the brainstem would be pulled into the spinal canal through the foramen magnum. And therefore, the cerebellum would be flattened, and therefore the sternum magna would be obliterated, and therefore the cerebellum would take on the shape of a banana. And the second sign is lemon sign, which I have already shown you. The head is just like the shape of a lemon. It is because when there is a suction force down there, the whole brain, the skull bone would also be sucked up, and therefore the frontal part would be indented, causing indentation on the frontal area, and then it takes up the shape of a lemon. And the third one is ventriculomegaly. When there is an open spina bifida there will be leakage of CSF, and there will also be obstruction of CSF flow by the cerebellum and the brainstem, and therefore the ventricle will be dilated because there is obstruction to CSF flow. So when you look at the brain, when you see banana sign, lemon sign, ventriculomegaly, you have to go to the spine to search for open spina bifida. Now, how do we know that there is spina bifida? First of all, we take a sagittal plane. Now, in the sagittal plane, normally you will be able to see the normal alignment of the skin and also the posterior elements and the body of the spine. But then in spina bifida, if it is an open spina bifida, you would be able to see a breach in the skin and a breach in the posterior elements. And sometimes if there is some meningocele or meningomyelocele, you would also be able to see a cystic mass here. And when you take a coronal section, normally you would be able to see a parallel tram-line appearance of the posterior elements. But then, if there is a spina bifida, the posterior element would be splayed out like this. And when you take an exoplane to examine each vertebra, and instead of seeing intact skin, sometimes you can't see the skin. If there is no skin, you know that there is an open spinal bifida. But the most important thing is to examine the posterior element or the neural arch. Normally it takes up the shape of a Chinese character egg, but in open spine, in case of spinal bifida, it would be reversed like this, So if you see something, the neural arch showing a reverse Chinese character egg, you know that there is an open, you know that there is a spinal bifida. And sometimes you can also see a cystic lesion here. So give you some real life example. Now, this is an example of myelomeningocele. Now, when you take a transverse section of the brain, you will be able to see first the ventriculomegaly, and second, the lemon head shape. And then when you look at the cerebellum in the posterior fossa, you would be able to see that instead of a dumbbell shape, the cerebellum is just like a banana. And then when you look at when you go to the spine, you look at coronal section of the spine, instead of parallel alignment, you can see that the posterior element just splay out. And when you look at the transverse section of each vertebral body, instead of seeing a Chinese character 8, you now see a reverse Chinese character 8. So this is a case of myelomeningocele. So these are still pictures, and I'm going to show you the video. So this is the lemon head, ventriculomegaly. And then when you look at the back, you'll be able to see, well, the banana here, instead of a dumbbell, there is a banana here. Okay, and when you look at the coronal section of the spine, you can see that there is a cystic mass here, and the posterior element just splay out. Instead of a parallel, it just splay out. And when you look at the transverse section, you can see the posterior element, a reverse Chinese character 8. And you look at the cystic mass here. This is a cystic mass with neural tissue inside. 3D shows you this thing here, which is a big defect at the back. And this is the photo showing you the myelomeningocele without skin covering. So the next case is myeloschisis or myelocele. For this case, there would be just a defect, no covering skin, no covering membrane, no cystic mass whatsoever. But this is an open spinal bifida, and then it will show all the signs of open spinal bifida. First of all, ventriculomegaly. Second, lemon-shaped head. And third, banana here, banana, and instead of dumbbell. And then when you look at the transverse section, well, you really can't see covering skin. And when you look at the posterior, let us take a look at this axial plane here, the sagittal plane here. And when you look at the skin, you can see a breach in the skin, the posterior element. You can also see a breach in the posterior element as well. And when you look at the transverse section, you can't see covering skin. And when you examine this neural arch, you can see that instead of Chinese character 8, you'll see a reverse Chinese character 8. So this is the baby here, no skin covering here, no cystic mass, just a hole at the back. So this is a case of meningocele. Now this meningocele is a closed meningocele, and therefore for all closed spinal bifida, you would not be able to pick up at the head signs, and therefore the head shape is normal, the cerebellum is normal, and there is no ventriculomegaly. But when you take a look at the sagittal section, you will be able to see this cystic mass covered by skin at the sacral area. And when you take a transverse section, you will be able to notice this. The posterior element, the Chinese character 8 is reversed. So you know that here there is an open spinal bifida here. So here normal, and then here reverse. And then there is a cystic mass here. And then the coronal section, you can also appreciate the cystic mass, and you can also appreciate how this posterior elements play out. And this is the fetus here. The abortus here. You can see a skin-covered mass, but you don't know what is inside. So this is the cystic mass, and this is the posterior elements playing out. So coming to midline defect. Now, midline defect, two categories. One is disorder of cleavage. It means that the brain failed to separate. It just fused together to form an abnormality called holoprosencephaly. And the second category is disorder of midline development, and the most important midline structure is the corpus callosum. And therefore, the most important abnormality you need to know is agenesis of corpus callosum. Now, first of all, let's go to holoprosencephaly. Holoprosencephaly is due to failure of brain cleavage, and therefore there will be no midline structure. There will be no falx cerebri, no CSP, and the ventricle will be just a single fused ventricle like this. Like this. And for the thalamus, sometimes it is fused and sometimes it is not. For this is partially fused. And holoprosencephaly, there are three types depending on how the degree of fusion of the brain. It is divided into three types: aloba, semiloba, and loba. Now, for aloba type, there will be complete lack of separation. So this is the most severe type. So this is normal. This is the aloba. You can see that no midline whatsoever, and there is a single ventricle. And the semiloba type, partial separation, you can see that the anterior part is fused together, but the posterior part is separated. The most common type is still the semiloba type. The loba type is the rarest, and because but it is the most difficult to pick up because the separation is near normal and the fusion is in the frontal lobe only. It's just here a little bit, and almost all of the brain is separated. And holoprosencephaly is usually associated with midline facial abnormalities, and this midline abnormalities also have different severity. And the most severe midline abnormality, everything fused together in the midline, forming a cyclope. And in this kind of a cyclope abnormality, you can't see a normal brain. Instead of seeing a normal brain, you will be able to see this proboscis here. This proboscis represents the nose, primitive nose, and with a single nostril here. And then below this proboscis, you can see a single eye or fused eye. So this is the most severe midline facial abnormality called cyclope. And the next one is very severe hypothyroidism. The two eyes are being very close together, and the nose just fused together to form one single nostril. And this one is another one, very severe hypothyroidism, and there is a central cleft lip here. Now, this is the most subtle one. You can see that the eyes are close together, but the most important thing is a single incisor. So if you see an individual with a single incisor, do think about holoprosencephaly. Now, the most common cause for holoprosencephaly is actually trisomy 13. 50% of the holoprosencephaly is caused by trisomy 13. Now, this is a real life example, and this video here, you can see that in the SU section of the brain, you can see that the frontal horn is fused together. I mean, this is a single ventricle. But then at the posterior part, the thalamus, there is a little bit of fusion. But it is also a little bit separated. So this is a semilobar type of holoprosencephaly. The most common is semilobar. So this is the video showing you the single ventricle, thalamus, somewhat fused together a little bit, but a little bit separated. And this is another look. This is a coronal plane, shows you the whole ventricle fused together. And then when you look at the face, you can't see a normal nose. Instead of seeing a normal nose, you see this. You see this proboscis, which is here, just like this one. And then when you look at the face, you can see that underneath the proboscis, there is a hole here. This is the nostril. And underneath the nostril, you can see the eye, single eye here. So this is a single eye. This is the proboscis. So this is a very severe type of facial abnormality of trisomy 13. Now, another case of trisomy 13 with holoprosencephaly, this is the axial section. You can see the single ventricle here. And the thalamus is somewhat fused but somewhat separated, so it is a semilobar type. But when you look at the eye, you can see the two eyes are very small, and it is asymmetrical and very close together. And when you look at their face, you can see the two eyes very close together, and most importantly, you can see the central cleft lip. And when you count fingers, 1, 2, 3, 4, 5, 5 fingers together with the thumb, so altogether 6 fingers, and this is called post-axial polydactyly. Now, whenever you see a case of holoprosencephaly together with post-axial polydactyly, it is definitely a trisomy 13. There is most of the time it is trisomy 13. So coming to agenesis of corpus callosum. Now, what is corpus callosum? I have already explained to you that corpus callosum is a large bunch of neural tissue connecting the two sides of the cerebral hemisphere. And this is the corpus callosum, and in coronal section, this is the corpus callosum. And this, the upper panel shows you agenesis of corpus callosum. You can't see any corpus callosum here, and you can't see any corpus callosum here. And how do we examine the corpus callosum? We take a mid-sagittal section, and then we will be able to examine the whole corpus callosum in its entirety. Agenesis of corpus callosum is very important, and it is very interesting as well because there are a lot of ultrasound signs, and there are direct signs and there are indirect signs. And in axial planes, you would be able to detect indirect signs. And the most important indirect sign is absent CSP. Now, in this projection, you can't see any CSP at all. And the second indirect sign is a 3-line sign. It means that why is there a 3-line sign? It is because the corpus callosum is absent, the two cerebral hemispheres wide apart, and therefore the medial aspect of the cerebral hemisphere, you can see the medial aspect of the cerebral hemisphere here, and therefore there will be 3 lines in between instead of a single white line. So this is what we call 3-line sign. And the third one is the teardrop sign. You can see that the lateral ventricle is just like a drop of tears because the frontal lobe, the frontal horn is very sharp and the posterior horn is dilated. So this is a teardrop sign. Now, when you do ultrasound scan of the brain, when you take a transthalamic and transthalamic plane and transventricular plane, when you see these signs, these 3 signs, immediately you know that you are dealing with a case of agenesis of corpus callosum, and therefore you have to do a targeted neurosonogram by taking coronal section and sagittal section. Now, this is the coronal section. The beginning, you can see direct signs. First of all, you can't see the corpus callosum, you can't see the CSP. Now, the corpus callosum is here, the CSP is here, but in this case here, you can't see the corpus callosum and you can't see the CSP. And when you look at the frontal horn, you would be able to see that the frontal horn are widely separated, and the shape is just like the bullhorn, and therefore we call it bullhorn sign. And this is when you see this, you know that quite definite that it is agenesis of corpus callosum. But then, without taking a sagittal plane, you will not be able to arrive at definite diagnosis, because in the sagittal plane, you will be able to examine the corpus callosum in its entirety. But then, in cases of agenesis of corpus callosum, you really can't see the CSP, and then you really can't see the corpus callosum. And when you examine the sulci, the sulcus, you will be able to see sun ray. So this is called sunburst sign because the medial sulci is radiating from here. And then when you study the pericallosal artery, in a normal pericallosal artery, it is a semicircular loop, looping on the top of the corpus callosum. But then when there is agenesis of corpus callosum, you would not be able to see this loop. Instead, you will see just haphazard radiating branches of the pericallosal artery. So when we see all this, we know that it is a case of agenesis of corpus callosum. Now, just to give you a real-life example of agenesis of corpus callosum in the second trimester. So this one, transverse section, immediately you see the teardrop, and immediately you can see the 3-line, and immediately you can't see the CSP here. So this is the teardrop, 3-line sign, no CSP. And in the coronal section, immediately you can notice the bullhorn. Immediately you can't see the corpus callosum and the CSP. So this is the coronal section, no CSP, no corpus callosum, and bullhorn sign. Now, when you look at the mid-sagittal section, you try to find the CSP and the corpus callosum, and here you really can't see anything at all. But instead, you see the sulci radiating like this. So this is sunburst sign. And when you study the pericallosal artery, you, instead of this semicircular loop here, you can see that there is some sort of a loop here, but it stops here. And you can see all these radiating branches. So these are the signs of agenesis of corpus callosum. Now, lastly, we come to posterior fossa. Well, I have already explained to you posterior fossa is an area that the cerebellum, cerebelliformis, and the sternum magna is situated. So you notice that this is the cerebellum hemisphere, vermis, sternum magna, and in the mid-sagittal section, you'll be able to examine the vermis in its entirety. So we take measurements. We would take the transcerebellar diameter from outer to outer, and we know that the transcerebellar diameter corresponds to the gestational age up to 22 weeks. It means that for 18 weeks, the transcerebellar diameter will be 18 mm, 20 weeks, 20 mm, 22 weeks, 22 mm. And then when you, if the sternum magna looks abnormal, we will also measure the sternum magna from inner to inner, and the normal value is less than 10 mm, just like the ventricle. And for posterior fossa abnormality, I like to introduce you to this cerebellar hypoplasia here, in which you can see that the cerebellum is very, very small. Very small. When you take when you measure the transcerebellar diameter, it does not correspond to the gestational age. And when the cerebellum is this small, then the space at the back, called the sternum magna, would be dilated, and therefore sometimes that would be the sternum magna. When you measure it, it might be close to 10 or even above 10. But when you look at its shape, the morphology, and the anatomy of the cerebellum, everything is normal. It is just small. Everything is normal. When you look at the vermis here, it is the shape is normal, but then you can compare it as small. So this is cerebellar hypoplasia. And the most important abnormality that you need to know is Danny-Walker malformation. Now, Danny-Walker malformation, their pathology is threefold. The most important abnormality is the hypoplasia and upward rotation of the cerebelliformis. Now, this is the cerebelliformis here, and this is Danny-Walker malformation. You can see that Danny-Walker malformation, some of the vermis is missing. And also you can see that this cerebelliformis is rotated upwards and posteriorly. And therefore, you can see that without the inferior vermis, when some of the vermis is missing, you can see that the fourth ventricle would be dilated, and it would be connected to the sternum magna, and it would form a big cyst at the back. This is what we call posterior fossa cyst. But the most telltale abnormality is look at the tentorium, which is the dura mater, separating the occipital lobe from the cerebellum. Now, usually the normal tentorium would be slanted downwards, but then for Danny-Walker malformation, it would be slanted upwards. So when we see that, we call it Danny-Walker malformation, which is a very serious and serious abnormality with a poor prognosis. Now, just to give you some real life example, now this is normal for you to compare. This is one of the example. You can see the two cerebellar hemisphere is separated, the vermis is missing, and the fourth ventricle is somewhat dilated and connected to a dilated sternum magna. So this is the Danny-Walker malformation, and the other example is also similar. Two cerebellar hemisphere separated, vermis absent, fourth ventricle dilated. For this one is strange because the sternum magna is not too dilated. So this is Danny-Walker malformation. So I have gone through with you anatomy, how to scan the fetal brain and spine, and also I have gone through some of the common abnormalities. And I'll stop here, and I would end with quiz. So Ms. Lai said that you have to take 2 questions for quiz. Now, just to show you the first question. So this is the transverse plane. This is the coronal plane. This is the 3D image. This is the abortus. So what is the brain abnormality? A, B, C, D, E. You just write down the answer. So the next one. So this is the transverse plane. This is the coronal plane. This is the mid-sagittal plane. What is the abnormality? So A, B, C, D, E, you just write down the answer. Better write the, don't just write A, B, C, D, E, you write the whole the whole name. So yeah, I'll stop here and thank you for your attention. And if you have any question, feel free to write me an email. Okay, thank you.
All right. Thank you very much to Professor Ting. So wonderful lecture, isn't it? So I have learned quite a lot from it. Also, very good revision also for me. So those of you who are in our front line in the peripheral district clinics, don't worry if you don't get to see all those. We understand that there's some limitation in your ultrasound machine, but at least try your best to help us identify major abnormalities. Some sort of counseling or intervention can be done early. In fact, just this week on a Monday, I had a referral from nearby Tuaran, and we have a patient with the open spinal bifida diagnosed in about almost 30 weeks pregnancy at the third trimester. So those are some situations that um, you can help us to detect much earlier. Okay, probably early in the second trimester, and if you really look hard and you get to see her in the first trimester, you may even detect these major abnormalities in the first trimester. Okay.
Recording stopped.
So we will take a short break. We will come back at 3:40 p.m. sharp, and we will start with Dr. Lee's lecture. In the meantime, if you have joined us and you have not fill up the attendance link, the secretary will post that link for the